Welcome to the Tic-Tective Podcast, a program of the Bay Area Lyme Foundation, where our mission is to make Lyme disease easy to diagnose and simple to cure. I'm your host, Dana Parrish, and I'm the co-author of the book Chronic, and I sit on the advisory board of Bay Area Lyme Foundation. This program offers insightful interviews with scientists, clinicians, patients, and other interesting people. We're a nonprofit based in Silicon Valley, and thanks to a generous grant that covers 100% of our overhead, all of your donations go directly to our research and prevention programs. For more information about Lyme disease, please visit us at bayarealyme.org. Dr. Matt Kaeberlein is a biologist and a biogerontologist. He's the CEO at OptiSpan, an affiliate professor of oral health sciences at the University of Washington, and he is co-director of a project very, very close to my heart called the Dog Aging Project, which you may already know him from. Dr. Kaeberlein's research interests are focused on understanding biological mechanisms of aging. He's published more than 250 peer-reviewed papers in the field of longevity and has received many prestigious awards. Dr. Kaeberlein is the founding director of the University of Washington Healthy Aging and Longevity Research Institute. Welcome, Matt. I am so excited to be here with you today.
Sure. Thanks for having me.
Okay, so I wanted to share something with you. I read an article on CNN about 5 or 6 years ago about the Dog Aging Project and about how there is a drug called Rapamycin that was really showing remarkable results in animal studies at lengthening life, improving cardiovascular health, oral health, also brain health. It's been on my mind for a couple of years. And my dog, Lucy, who is now 15-and-a-half-year-old Tibetan Terrier, she was significantly poisoned when we were living in California a few years ago by an herbicide. She went deaf. She began having seizures immediately, and she was showing signs of Parkinson's, basically what you would see in a person. Lots and lots of tremors, a whole personality change, sort of the light went out in her eyes. I consulted multiple toxicologists. What do I do? They said, well, this is a sign of what it's going to do to you over time if you stay in this environment and are exposed to this chemical over and over. These are the sources of neurodegeneration, these kinds of things. Obviously, there's many factors, so I'm not saying it's all or nothing. So they said, we suggest that you move, and also you want to save the dog, and you can't keep her in that environment. See what happens. Take her out of the environment. Right. After 5 days, the seizures calmed down. They completely go away. Took her to a neurologist. They were going to give her all kinds of medications. She never needed any of them. Fast forward to, a couple years of living in California, jumping in and out of a car for the first time in her life. She's already like 12, 13 by then. And she's starting to show signs of arthritis in her back and her hip. And so, start picking her up, blah, blah, blah. But it just seemed like long walks were now no longer going to be possible. And she did seem to be in pain sometimes. And keeping dogs on, just like with people, on NSAIDs, for a very long period of time is not ideal. Fast forward to remembering that article, going back and reading it, and doing some Googling around and finding that there are actual trials to put dogs in for rapamycin. I am not kidding when I tell you, and I know I sent you a video of Lucy at 15 years old, running down a dead-end street at full speed, jumping over a non-existent curb, which is like hysterical. She turned into a puppy again. I am not making this up. Neurocognitively, amazing. Like the light is all back. She's feisty. She's very mischievous again. And her arthritis is basically gone. And so I wanted to tell you, thank you, because I think it's really you guys who brought that to my attention. And it's incredible. And I'm so curious to talk to you about the Dog Aging Project, of which you are a founder. Can you tell people what that is? Are my results crazy? Like you hear this stuff all day?
Sure. Yeah. So let me just first comment on your experience, which is, first of all, I'm a scientist by training. I have been studying rapamycin for, almost 20 years now in various contexts. And so part of me is like, well, we really need to do the randomized, double-blind, placebo-controlled clinical trial to prove that this is actually due to the rapamycin and that it has all of these benefits in dogs. What I can say with confidence is what you're describing is what we know rapamycin can do in laboratory animals. So in mice, we've seen that rapamycin treatment can increase lifespan by up to about 25%, but maybe more importantly, it seems to have positive impacts on a whole bunch of age-related functional measures, including, you mentioned heart function, reversing periodontal disease, improving ovarian function in aging in mice, delaying dementia, and improving muscle function, right? So the things you're describing are consistent with what we've seen in laboratory animals. Part of what we're doing with the Dog Aging Project, which I'll talk about in a minute, is really trying to now answer that question in a very rigorous way in companion dogs or pet dogs living with their owners in the real world. What you described, though, is certainly consistent with anecdotal stories that several people have told me about their own experiences with their dogs, giving them rapamycin, and also what people have told me who have taken rapamycin. And I've publicly talked about, my experience with rapamycin. So I first took rapamycin about 4 years ago now, because I had been diagnosed with something called adhesive capsulitis, which is also known as frozen shoulder, inflammation of the shoulder capsule. And it got to the point where I couldn't sleep. I couldn't go across the street and throw a football with my son. Finally, I went in and got it diagnosed. And, rapamycin, I believe, certainly I can't prove it wasn't placebo effect, but my experience was I started taking rapamycin and it cured my frozen shoulder. So I think
how long did it take? And how many, how did you take it?
I knew within 3 weeks that it was getting better. And I had gone into that with a very defined, like, I'm going to do it for 10 weeks and I'm going to take 6 milligrams once a week. And then I'm going to stop and see what happened. And by the end of the 10 weeks, it was 95% range of motion was back and the pain was essentially gone, and it hasn't come back. So again, I can't prove it wasn't placebo effect, but for anybody who's ever had frozen shoulder, it is really painful, especially if it gets to the point where you can't sleep at night. It's hard for me to imagine that wasn't the rapamycin. And that's very biologically plausible given what we know rapamycin does. It's a very potent at knocking down age-related inflammation, which is exactly what frozen shoulder is. So it kind of makes sense. What you're describing, it fits with a lot of what we have seen both in the controlled laboratory studies and also in people giving their dogs rapamycin or people using rapamycin off-label. Having said that, I still feel like, we really have to have the rigorous clinical trials before the veterinary community or the medical community is actually going to buy in and believe this. And also to demonstrate safety, right? I think there's a lot of concerns around rapamycin. Is it safe? Given the way it was developed as an organ transplant medication. It was used at high doses in organ transplant patients. And in that context, there are some side effects associated with the medication. At the lower doses in healthier dogs and people, we don't see those side effects, but still, I think you really need the clinical trials to demonstrate safety and efficacy. So what you described makes sense, but I still feel like we really need to have these clinical trials, which is, again, part of the rationale for the Dog Aging Project and the clinical trial component of the Dog Aging Project. So I'll take a minute and describe the Dog Aging Project, and then we can go from there. So the Dog Aging Project is something that, really we started about 10 years ago. And when I say we, myself, Daniel Promislow at the University of Washington, and Kate Creevy, who's at Texas A&M University, around this idea of, can we study the biology of aging in dogs in order to understand the genetic and environmental factors that influence disease and health outcomes as dogs are aging, both because that's important in dogs. We're all dog lovers, right? So we recognize the value of being able to increase health span in dogs, but also because the biology of aging is very, very shared between dogs and people. And so the things we learn in dogs are also likely going to be relevant for human aging. And so we started trying to build this project, and it took about 5 years to get the first NIH grant to do this. And that grant was funded in 2018. And the goal of that grant was really to build what we call a large-scale longitudinal study of aging. And what that means is just follow dogs throughout their lives. Don't really ask the owners to do anything different than they normally would, but collect a lot of information about the dog's environment, their diet, their genetics, their prior health history. And as they're getting older, correlate things with diseases and health outcomes and lifespan. So that's the goal of a longitudinal study of aging, is to really identify factors that influence health outcomes during aging.
Yeah.
That we have about 50,000 dogs in the Dog Aging Project longitudinal study of aging today. So it's really been quite successful at engaging people in this open science, community science project.
Is there an
A
average
sub
age of the dogs where they are allowed to start
So
being
the
part of
dogs can
this?
come into they can come into the longitudinal study at any age. It's open to all breeds, all body sizes. We really want that diversity, and we can talk
Mm,
more about the diversity of dogs, but we really
yeah.
want to capture that diversity of the companion dog population. So the longitudinal study is open to all dogs, regardless of size, breed, sex, sterilization, any of that stuff.
Okay.
But within the longitudinal study, there's a subset of about 500 dogs that are part of the clinical trial. So again, most of the dogs, we're not asking the owners to do anything different than they normally would. Within the
Okay.
clinical trial, that is a true randomized, double-blind, placebo-controlled clinical trial of rapamycin. Half the dogs get placebo, half the dogs get rapamycin. I said
Hmm.
double-blind, I guess triple-blind if you include the dogs. So the veterinarians don't know, the owners don't know, presumably the dogs don't know whether they're getting the placebo or rapamycin.
Okay.
Um, and so for that clinical trial, the dogs do have to be at least 7 years old and at least 40 pounds in weight, or between 40 and 110 pounds. We can
Okay.
talk about why those criteria in a minute, but the goal there is really to answer the question, does rapamycin increase lifespan? That's what's called the primary endpoint. So we are statistically powered to detect a 9% change in lifespan from rapamycin, and that's
Mm,
based on mouse data. But of course, we're interested in health span as well. So we're measuring a whole long list of health metrics to see whether rapamycin can improve those health metrics as well. So things like cardiac function, cognitive function, neurological function, activity, because based on the mouse studies, we expect that rapamycin, if it's really affecting the biology of aging, should improve those functional measures as well. So that trial, again, officially the grant was funded in 2018. We spent about 2 years building the infrastructure. And then, of course,
hmm.
COVID-19 happened. So we're
Yep.
about half enrolled right now. And hopefully we'll be able to continue that trial. We'll talk, I assume, about the funding challenges that we're facing right now. But hopefully we'll
Yeah.
be able to continue that trial and answer the question, does rapamycin actually affect aging in dogs?
I know we don't have the data yet, but what's your
Yeah.
sense just hearing from people like me? And I'm sure you've got friends and family who have pets on them.
Yeah. So what I can tell you with confidence, so before we started the large clinical trial, we call that triad, test of
Hmm.
rapamycin in aging dogs. We
Uh-huh.
did do two smaller clinical trials. Those were primarily for safety, but we did also look at a couple of other metrics of health. So in the first clinical trial, we saw evidence that the dogs that got rapamycin, again, these were double-blind, randomized, placebo-controlled. We
Yeah.
saw evidence that the dogs that got rapamycin had improvements in heart function by echocardiography, which is pretty interesting and
Hmm.
matches what has been previously seen in mice. And also more recently seen by a company called Trivium Vet in cats with heart disease, which is, we can talk about that. That's pretty interesting as well with
Yep.
rapamycin. So that I think is probably real. And then the owners reported, and again, remember, they didn't know if their dogs were getting rapamycin or placebo,
Sure.
increased activity in both of our smaller clinical trials leading up to triad.
That's so
Yeah,
interesting.
so it is interesting. So it's not quantitative. Unfortunately, we didn't have activity monitors on those dogs, but the owners self-reported increased activity and increased energy. And the fact that they didn't know, whether their dog was getting rapamycin or placebo makes that, I think, relatively high quality data. So that's what we know with confidence. And then, as I've already alluded to, I've had multiple people sort of tell me stories like yours where, they start giving rapamycin to their dogs and they can notice a significant difference in a variety of behavioral or health metrics. Now, I will say, this is speculation. My speculation is that it's probably not having that large of an effect in every dog.
Okay.
And we actually saw a hint of this in our first clinical trial. So when you look at the heart data, overall, in the dogs that got rapamycin, heart function was improved, and that was statistically significant. But if you look at an individual by individual level, the dogs that came in with lower heart function at the
Hmm.
baseline were the
Yep.
ones where you saw the improvement. The ones who had pretty good function, you didn't really see any improvement. So I think it's going to depend on where the dogs are functionally in these different metrics of aging, and also potentially what's driving that loss of function. So again, my speculation is that rapamycin is quite potent at improving um, functional measures that are driven by age-related inflammation, because
Uh-huh.
we know that that's one of the things rapamycin is really, really good at knocking down. Other age-related changes that aren't related to inflammation, I don't know whether rapamycin is going to have an effect or not. I'm pretty confident that at least for some individuals, absolutely, rapamycin has benefits. I think the other remaining question, though, is, what does the long-term, are there any long-term side effects? And we don't know the
Yeah.
answer to that at this point. I just can't with confidence say 100% that there are no side effects in the long term. I think we can say in the short term, it's very safe. Short term being like up to 6 months or a year. We really don't have the long-term data. And I'm only saying that out of an abundance of caution. I don't have any reason to think it's going to cause problems long-term, but I just recognize until you actually have had dogs on it for several years, you can't really answer that question.
I see. Just speaking from my own personal experience, I guess we put Lucy on it something like 7, 8 months ago, and she doesn't take it every single week. I don't give it to her every week. At first I did, and then I was seeing these very significant benefits, and they were durable. So
Yeah.
I just try like sort of less is more. If I see that she's starting to get a little flare, put her back on, see another, and then I'll keep her on for a couple of weeks. So I've been doing my own cycling, which is
Yeah.
probably very different than even what the big biohackers do and what is recommended. But I'm just sort of going by instinct, watching her, and I feel. Here's the thing too. When I first started her, I had her on a low dose. The vet had said she's just a drug sensitive dog, so we're
Hmm.
going to start her on, I think, like a third of what you would. She's about 29 pounds, about a third of what I would normally give to a dog, 29 pounds. I think you started her on a 0.5 milligram, if that sounds
Okay.
about right. In terms, that's low.
Yeah.
Okay,
Yeah.
something like that.
Yeah. Once a
So
week.
well, at first it was 3 times a week. And then I decided
Okay.
after watching your talks and reading more, I was going to do, I found the same benefit once a week. But at first
Yeah.
we were giving it to her 3 times.
Yeah.
First day I gave her the 0.5 milligram. And because I was under the impression it was such a underdosed dose for her weight, had no concerns about it. Well, I felt that it really did have some side effects in putting her on that dose. Some
What
GI
kind of side
stuff,
effects?
GI, and
Yeah, that's the
also
most common thing you see in people, that and mouth sores. So that makes
okay.
sense.
Yep, GI, but also I felt so I know you know probably a lot about chronic infections as well, and more like Herxheimer reaction is what I would describe it as, like an exacerbation of symptoms. And I've heard some people who are very knowledgeable about chronic infections and also know some stuff about rapamycin
Yeah.
say, oh, it must have been like a Herx-like reaction, kind of. And that was my perception, although I have absolutely no evidence that that's what it was. So what I did was I talked to the vet. He's like, totally cool. If you want to open the capsule, pour half of it out, pour it into another little capsule, and then give her half of that. So 0.25 milligrams. Magic. Freaking
Hmm.
magic. No side effects. And now I'm titrating her up slowly. So she's now on the 0.5 milligram, and it's fine once a week. Absolutely no problem. Um, I could get her higher, but a friend of mine just said to me the other day, why would you? Like, why would you bother?
Yeah.
So I'm just wondering what you think.
Yeah. So there's a whole bunch of interesting stuff to unpack there. First is, I think around the cycling, right? So you mentioned like that may not be what's recommended. First of all, nothing's
Yeah.
recommended. It's
Yeah.
like people are doing all sorts of stuff. So
Yeah.
we did a study actually of people using rapamycin off label. We published it middle of last year. The
Mm.
most common dose in humans is 6 milligrams once a week, but people are doing all sorts of stuff on both sides of that, daily dosing, in our first clinical trial in dogs, we did do 3 times a week, and then we
Mm.
backed off to once a week, and we changed
Mm.
the dose a little bit. All of that is just to say there's a lot of guesswork involved. And unfortunately, even with FDA approved drugs, very rarely does anybody actually do a dose optimization. Once a company gets their drug approved, they go with it. And then if they find problems at that dose, they'll back off or go off. But
Yeah.
very rarely do we get dose optimization. The cycling, I think, is really interesting. And that's what I have adopted for myself as
Mm.
well. So,
Mhm.
I mentioned this frozen shoulder. I took it for 10 weeks. It seemed to work and work quite well. And, what we've seen in mice is if you treat them for anywhere between like 8 weeks and 3 months, you get a potent inhibition of inflammatory responses. You get improvements in all sorts of age-related functional measures, and that lasts for a while. And I think that's in part because it takes a while for the inflammatory signaling to kind of come back up, right? And then maybe it makes sense to dose again. So that's what I've been doing personally. And honestly, I've been
Oh,
kind of doing what it sounds like you've been doing with Lucy, which is you kind of wait until it seems like she needs it again, right?
Exactly.
And I do the same thing when I do a lot of resistance training, and when my elbows and wrists start to hurt, I'll take rapamycin again. And,
That's so
again, it's
great.
not scientific. Like, I'm a scientist and I recognize that's not really a scientific way to do it, but it is biologically plausible.
Yeah.
And it seems to work. And I'm of the same mind, which is that you kind of reduce any, if there are real risks, you kind of reduce the risks by doing that sort of cycling where you only use it when you need it. And I would agree with the dose as well. Like, why would you want to push it higher? And I know some people do this in the biohacking crowd. There's this minority that's like, let's see how high we can push the
Yeah.
rapamycin,
Yeah.
But why would you don't need to do that necessarily. Maybe there are some benefits. I don't know, but certainly the risks go up. So if you don't need
Yeah.
to, why push it? So I sort of agree with the philosophy that you've got. Like I said, that's more or less the way I apply it in my own use.
I'm thrilled to hear that. Oh, well, one thing I do have that's measurable that you may find interesting. So, just because I have an iPhone and it tracks how far I walk every day, I often track how far I'm walking with the dog because I want to know if she's getting durably better or if I'm just like
Yeah.
imagining it, right? She has been walking with no problem up to 4 miles a day. She wasn't walking 3/4 of a mile before we instituted the Rappa. 4 miles, and she's still dragging me after 4 miles.
Wow.
It's not like she's dying to come home. It's like I want to go home. So I think it's just honestly,
Yeah.
I
It's
wouldn't have
exciting.
believed it. I wouldn't have
Yeah.
believed it if you would have if I didn't see it with my own eyes.
Yeah, and I mean it's great, right? That's really really fantastic for you and for
Yeah.
her
Yeah.
and to learn about. I mean, again, I always have to say, like, we can't be 100% sure it's rapamycin, but when you start to hear enough of these stories, right, it does create, I think, a pretty good case. You mentioned the bacterial infections. I mean, that's the one thing that I would like if I had to point to something I would watch out for.
Yeah.
If you are using rapamycin yourself off label, or if you are giving it to your dog off label, first is do it under veterinarian or doctor care. Like, I
Sure.
really don't recommend people buy this stuff offshore. And, I think you want to make sure that you've got the care in place in case there is a side effect,
Yeah.
and be aware that there could be an increased risk of bacterial infections in particular, so that you can catch it early and take action if necessary. I can't say with certainty that there is. In our study of off-label use of rapamycin,
Hmm.
we did try to assess whether there was an increase in bacterial infection in the people using rapamycin off-label compared to people who'd never used rapamycin. We
Mm.
didn't see any statistically significant evidence, but there was a slight increase. It just didn't reach that level of statistical significance. The only
Okay.
thing that was significantly higher in the rapamycin users was mouth sores. We've never seen
Yeah.
that in dogs. We've never gone looking for it, so I can't say whether that happens in dogs or not.
Yeah.
But in people, that does seem to be a real side effect, even at the lower off-label doses that people are using.
Is there
About
no
15% of people.
yeah, I've heard you guys talk about this. And is there any mouth rinse or any sort of thing you can do to prevent that?
I was going to say, I don't know that you can prevent it. I know people use things like hydrogen peroxide, or there are some other
Yeah.
tools you can use if you get canker sores. I mean, they're basically at the doses that people are using it off label. I don't think this is published yet, but one of my colleagues is now looking at it closer at that data. So in the organ transplant patients, at the high doses, taking strong immunosuppressants, they get these really, really bad mouth sores, which can often be so bad that people stop taking the drug. At the off-label users, it seems like it's more akin to like a typical canker sore. And
Okay.
so I've never experienced that myself, but I have talked to lots of people who say you just kind of do the same thing you would do for a canker sore. Some people just ignore it, but then there are these over-the-counter remedies that people use for canker sores, and they seem to work okay. That's my
Okay.
impression.
Great to know. I wonder, talking about microbial stuff, in terms of an acute infection, I guess that's probably what you're talking about. People had increased infection.
It could be like a chronic thing if the dog is prone to chronic infections, that rapamycin could exacerbate that. And the same in people. Like in our study, I don't know that we had the resolution to know like what kind of infection it was, what were the conditions, or was it like an acute respiratory infection? Or I think mostly this is now speculation, so this is not data based. This is just from talking to people. I think a lot of times it's like skin infection kind of
Oh,
things.
interesting.
Yeah.
Okay. I guess what I'm getting at is, coming from the vector-borne disease world, where we're dealing with a lot of
Right.
chronicity, dealing with a lot of persistent pathogens. Certainly dogs are susceptible to the same ones that humans are, although they handle them better most of the time, like Lyme, things like Lyme and Bartonella. But they do cause arthritis. They do cause neurodegeneration. They do cause cardiac issues. I was a victim of Lyme carditis. And I actually got extremely sick and like almost died in 2014, 15. Because I'm hearing you say, and I'm looking at the animal data where it is helping. I'm watching Lucy with these inflammatory conditions and these cardiac conditions, which in my mind, some of them must be caused by microbes. Lucy also had Lyme at some point. Could it have an antimicrobial benefit that we don't know about, or do we know?
So here's what I would say. First, if you're looking at bacteria versus viruses, first of all, we can put them in those two classes. Those are the two main types. You can get yeast infections. Rapamycin is actually a potent antifungal. So if anything, it's going to impair yeast infections. But if we then look at bacteria and viruses, the data are pretty suggestive that rapamycin increases antiviral gene expression. So if anything, it's probably going to boost resistance against viral infections. But the infections I would be more worried about are bacterial infections. And they're, if anything, rapamycin, while you're on it, might reduce the body's ability to fight off bacterial infections. The interesting thing with rapamycin is a transient treatment, 6 to 12 weeks, seems to be pretty good at actually restoring what I would call immune homeostasis, so that after you stop taking it, your immune system is actually boosted if you're older compared to where it was. There you would expect to get resistance against all sorts of infections. But I would also say, I think Lyme and other inflammatory driven diseases are interesting for a different reason, which is that rapamycin may or may not do anything to the microbial component. I think a lot of these diseases, long COVID's another example, are really not so much driven by the infectious agent itself. It's the body's inflammatory response to the agent. And that's where rapamycin is gangbusters. Like, it is really good at knocking down that inflammation. So again, in our off-label study, it was a small study. Again, you really have to take these things. It was self-reported. You have to take it for what it's worth. But I think there's value in these kinds of studies. In that study, there was a statistically significant decrease in the people taking rapamycin in both severity of COVID-19 infection and likelihood of suffering from symptoms that are consistent with long COVID. I've been saying for a long time, I think rapamycin has a lot of potential in people who are suffering from long COVID. And there's really almost no downside to doctors prescribing it for 6 weeks, 12 weeks. Just see if it helps, right? And I think it probably will for a lot of people. Probably not everyone, but I think it will for a lot of people. Lyme disease is also another super interesting case where I've talked to people who had chronic Lyme who took rapamycin and their symptoms got better. So again, I'm not claiming it's going to work for everybody. I don't know. I would love to see a clinical trial, but I think these things that are at least in part a chronic inflammatory condition, there's reason to think that rapamycin could be beneficial for some of those people.
That's fascinating. That is really, really important, because not that many people are talking about it in these terms. It's been ongoing for so long. People don't have any symptom relief, even in spite of the best treatments, the best doctors, the best intentions. This seems so promising to me.
It's such a no-brainer. And again, I think part of it is just getting the word out there. And also, I think we're starting to see that more physicians are becoming comfortable prescribing rapamycin off-label. I think, you could say appropriately so. There was a lot of concern because of the organ transplant literature about side effects. I think now we're starting to learn that there really probably aren't any significant side effects from low-dose, short-term use of rapamycin. So as more physicians become comfortable, you'll probably start to see more of these case reports trickle out there, and then maybe somebody will finally do these larger clinical trials. But unfortunately, rapamycin's off patent, so there isn't the incentive for the pharmaceutical companies to do these sorts of clinical trials. But again, I think anything that's autoimmune related would be on the list of things you would want to look at, or that's related to chronic inflammation. And those are overlapping, obviously. Again, I'm not saying rapamycin is going to work for everybody or for all of these conditions, but for a subset of them, there's good data in the literature, and there's accumulating data from people using rapamycin off-label to suggest it's going to work for some of these conditions.
I think one thing that we should, if we could just expound upon it a tiny bit more, is that small study for COVID with Rapa, where I heard you talk about it before, and you said that people who were taking it before COVID, but not during COVID, no great benefit during COVID.
Right.
People who took it after, just plain old after, not before, no great benefit. People who took it during the acute infection did significantly better. That is extremely important to me. COVID is all about, at this point, the long-term chronic part of it, also the pathogen persistence part of it. I'm very concerned about the long-term stuff I'm just seeing among friends and family.
Yeah. And let me just clarify something, which is that you're right. So the way that we did this was, this was all after the fact, survey-based, collecting information. I think we had 333 people who had taken rapamycin off label, and then like 150 or so who'd never taken rapamycin.
Yeah.
So those are the comparison groups. But within the rapamycin group, we could put those people into different buckets, right? As you mentioned, we had people who were taking rapamycin when they got the infection and then continued to take it all the way through.
Yep.
We had people who were taking rapamycin when they got the infection, but then stopped because they were worried that rapamycin would affect presumably because they were worried that rapamycin would affect the severity of the disease in the wrong direction.
Yes.
Or we had people who hadn't started taking it until after their COVID-19 infection. And so we could ask, were there differences in those groups? So for long COVID, we just didn't have enough people who had been diagnosed with long COVID to really make a comparison between those who'd only taken it afterwards versus those who'd never taken it. So I wouldn't read anything into that part. But in terms of the severity of the acute infection, and I think we defined it as, like number of days that you had symptoms, and then the severe cases were a hospitalization, right?
Yep.
And so for severity, those who took rapamycin all the way through had a lower likelihood of a moderate or severe outcome. If we compare those people to those who stopped taking it or who took it only after their infection, there wasn't any difference in those groups, at least statistically, compared to people who never took it. So that's suggestive that at least for severity of infection and symptoms afterwards, taking it all the way through was better than stopping taking it. Okay, so I think that's what I would conclude from that data. But for long COVID, I don't think we can say anything other than it seems like people who took rapamycin all the way through were less likely to have symptoms associated with long COVID compared to people who'd never taken it. I don't think we know about taking it afterwards and any effects on long COVID symptoms because our numbers were too small. So now dose. The answer is I don't know. I mean, again, the doses in our group were so variable that in fact, I don't think we actually did the analysis you're asking about. We should go back and do it, which is, among the people who took it all the way through, were there any differences between people who took 6 mgs once a week or 2 mgs once a week or 1 mg daily? I don't know the answer to that. I don't know if our N is big enough to answer that, but it's an interesting question. There is potentially the opportunity for preventative treatment here. Again, it's speculative. Like we know that treating old mice with rapamycin for 6 weeks improves the ability of the mice to respond to a vaccine, an influenza vaccine. So it improves their immune function, just that 6-week treatment going forward for some period of time. We don't know how long that lasts. There's data in people. There were 2 phase 2 clinical trials done by a scientist named Joan Manick, fantastic scientist, showing that a derivative of rapamycin called everolimus, it works exactly the same mechanism. So I think it's safe to say rapamycin would have the same effect. That this derivative of rapamycin, given to healthy older people for 6 weeks, does the same thing. It improves flu vaccine response. And then they did a phase 3 with a different drug that also targets the same target as rapamycin. So rapamycin is an inhibitor of a protein called mTOR. They had a different drug that inhibits mTOR. And that data suggested that people who got this other drug, RTB101, for 6 weeks were in the following, I think, 6 months or 9 months, were less likely to have infections. And this was in 2019. Okay, so before we knew of COVID-19, but there were other coronaviruses out there, just we didn't know about COVID-19 yet. So for influenza and coronavirus and one other viral family, I can't remember off the top of my head, 6 weeks of treatment with this mTOR inhibitor led to significantly lower frequencies of infections with those 3 viral families over the next 6 or 9 months. So there may be opportunities here for, again, short-term treatments to have longer lasting benefits. And I don't know the mechanism, but I speculate, again, that with age, there's this perception that immune function declines with age. And that's only half right. immune function towards the things we want it to fight off, like cancers or infectious agents, declines with age. But there's an increase in immune function towards things we don't want it to target, like our cells. That's
Yeah.
autoimmunity, right?
Right.
So there's this shift. And I think really what rapamycin does is it kind of brings everything back down to a baseline and restores that immune homeostasis over something like 6 to 12 weeks. And at least in some people, then that rebalancing leads to persistent benefits for a while until the sterile inflammation, the autoimmunity starts to creep back in. So again, that's pretty speculative. I'm not an immunologist, so it's a very simplistic model, but I think there's probably some truth in that. I think it definitely is an immune modulator. I think it's fair to say that it is an immune suppressant towards at least some activities of the immune system. But as I've sort of already alluded to, there's evidence that it actually increases antiviral gene expression. So it's not like you're blasting the immune system down to zero. You're changing it a little bit. And again, this is where my limited understanding of immunology really shows itself. I don't know why, but it is my impression from looking at the data that rapamycin is very potent at knocking down the aspects of immune function that become hyperactivated with age, this sort of autoimmune sterile inflammation component that we don't really want in most cases. That's what rapamycin is really good at knocking down. And I wish I understood why, but I can't. I'm not an expert in everything, and I've tried really hard to learn immunology. It's like a different language, and I failed so far.
No, but that's all really helpful. So I'm curious, like, does Rapa get into the brain? Does it cross the brain-blood barrier as a pill? And then I have a question about inhaled Rapa. Is this a better option for people with possible neurodegenerative stuff or neuropsych stuff related to an immune hit?
Right. So I think this question of how effectively does rapamycin cross the blood-brain barrier, get into the brain, is still a little bit of an open question. So there is absolutely data that mice and people taking rapamycin, you can measure rapamycin in the brain, but it probably isn't very effective at getting into the brain compared to the amount of rapamycin in the rest of the body, at least if it's taken orally, right? Okay. So not talking about direct injection into the brain or intranasal or anything like that. Or if it's injected into the peripheral circulatory system. So it probably does, but maybe not as effectively. What I can say with confidence, for sure in mice, is I mentioned rapamycin is an mTOR inhibitor. Mm-hmm. If you give mice rapamycin in the food, you will see inhibition of mTOR in the brain. So sort of regardless of whether the molecule rapamycin is getting to the brain, it's having the biochemical effect in the brain that we would expect it to have in the sense that it's turning down mTOR. So that is rock solid. And then again, in the mouse literature, there is like literally dozens of studies showing that rapamycin is effective at reducing or even partially reversing dementia. So in pretty much every mouse model of dementia, Alzheimer's disease, Parkinson's disease, other dementia models, rapamycin is effective in those models at reducing certainly the functional deficits and sometimes the molecular plaques and tangles. That's a little bit less clear in the literature, but certainly the functional deficits is effective. And then also in normative aging. So mice who are just allowed to age out normally, not engineered to get Alzheimer's disease or anything else, they do show significant cognitive declines. They don't get Alzheimer's disease, but they do show cognitive declines associated with normal aging, and rapamycin is effective at preventing that as well, or at least attenuating it. So there's a ton of reason to think that rapamycin has benefit.
Could it possibly accelerate? Again, I understand we don't have the data, but I'm sure you'll hear from like the big aging doctors who are treating some of these patients. Like, I'm curious, what are they saying? What are they seeing?
Right. So the first thing I would say is everything has a risk reward, right? And so you kind of have to try to evaluate in as unbiased and comprehensive a way as you can that sort of risk reward equation. So just as a hypothetical, somebody who's ApoE4 homozygous, in their 50s isn't yet seeing any evidence that they are experiencing cognitive declines, early onset dementia, but they know they're at about a 5-fold higher risk of that outcome. The risk of developing dementia is relatively high.
Yeah.
So the reward, if rapamycin works, is also relatively high.
Yeah.
So then you have to ask, what's the risk associated with rapamycin? And at this point, we've kind of already talked about the common side effects we'd be worried about, what you might pay attention to, mouth sores, maybe a little increase in bacterial infection risk. But outside of that, I'm not aware. Maybe, you'd want to monitor blood lipids and things like that, which you should be doing anyways. I'm not really aware of any evidence that there's any significant risks outside of those. And to me, again, this is where it becomes sort of a personal decision along with your doctor. To me, that risk is pretty low compared to the potential reward. Now, is it possible rapamycin would accelerate dementia? It's possible. Again, I'm a scientist. I can't say with 100% certainty that that's not possible. I don't know of any data to support that. I don't know of any plausible biology that would suggest that, other than, maybe if you pushed the dose really, really high, way beyond probably even what organ transplant patients are taking, then you could come up with a biological mechanism where, sure, rapamycin could have negative consequences in that context. But at the doses people are using off-label, I can't think of any reason to think that's a risk. And I have not heard of anybody reporting that they have experienced symptoms associated with accelerated cognitive decline who've been using rapamycin off-label. So that's all I can really say on that sort of evaluation at this point.
Do you know anything much about inhaled Rapa? Intranasal Rapa? Okay.
Yeah, I don't. And I haven't, I guess I should look into it. I don't really know what studies have been done. I know that, this is sort of becoming more common, not rapamycin, but many drugs in particular being delivered intranasally, get better delivery to the brain. I don't really know of any data from intranasal delivery of rapamycin. It kind of makes sense. I do know, this was years ago. I was talking to a scientist who had been working with intranasal insulin for Alzheimer's disease. There's pretty good evidence that intranasal insulin can impact some of the pathways involved, we think, in the progression of Alzheimer's disease. And we talked about intranasal rapamycin and trying to design a clinical trial around that. Just never were able to move it far enough along or get funding. So I don't know what's been done. I guess I should look into that and really see if there's data suggestive that maybe that is more effective at reducing mTOR signaling in the brain and potentially getting delivery to the brain, because you might anticipate that could have benefits in dementia. Although I will say this is something that I think we don't really know with rapamycin yet, which is when we see these effects in specific tissues and organs, right? So we think of the brain as a specific organ, right? We don't know if that's due to the effects of rapamycin in that organ or if it's due to the effects systemically, and particularly the immune effects. There are so much of the systemic dysregulation, I think, with aging that is immune driven, that you could hypothesize that many of the benefits of rapamycin, say in the oral cavity, for example, are really due to its effects on the immune system, and then the ability of the immune system to modulate the microbiome or modulate inflammation in these different tissues and organs. I think anti-cancer effects with age are another good example of this. Many people don't realize this, but our immune system is really our most potent anti-cancer mechanism. We're getting cancers all the time, and our immune system is clearing it. That ability of the immune system to clear cancers declines with age, which is probably driving, at least in part, the acceleration in cancer incidence with age. If rapamycin is successful at restoring immune homeostasis, you might actually see a boost in the ability of the immune system to clear those cancers. So it could be a cancer in your liver or your pancreas that's actually being cleared, but it's your immune system that's doing it. So I just think we don't know how much of this is tissue specific driven versus systemic immune driven effects of rapamycin. So here's the thing. So, it's funny because rapamycin was really, when it was first being developed, I think there was a lot of hope that it would be sort of this, across the board anti-cancer drug, because in cancer cells in the laboratory, if you put enough rapamycin on them, they will stop dividing. But in our bodies, it's hard to get the rapamycin dose that high. And many of our cancers, they develop mutations. So cancers, once they take off, they start to develop all sorts of mutations and evolve very rapidly in our bodies. And many cancers evolve to ignore the mTOR break. So when you treat cells with rapamycin, you turn down mTOR, and that basically stops the cell cycle in normal cells. Many cancer cells, because of mutations, evolve to ignore that signal. And so rapamycin is not going to be effective there because the cancers have evolved to not pay any attention to rapamycin.
Right. Right.
But those cancers are still susceptible to our immune clearance. So if you can boost the immune system with rapamycin, you could potentially clear those cancers. I don't know whether that happens in people. What I can say, the data in organ transplant patients is tricky because, again, they're taking high doses of rapamycin. They're taking other immunosuppressants. There, I think the data are suggestive that most cancers are reduced, but cancers of the immune system are increased. So blood cancers are increased in those patients. So I don't know what that means. But in mice, taking rapamycin, where we see lifespan extension, all of the cancers seem to be delayed. So it doesn't, those mice still get cancers, but they are delayed at least proportionately with the lifespan extension. So it does seem that rapamycin is having some anti-cancer or delaying effect on cancers in the mice that are long-lived.
Are there other drugs that should be trialed, or maybe that are being trialed or have been, that we may not know about in the long COVID, chronic Lyme, ME/CFS world, other than rapamycin?
Well, I'm sure there are. Again, rapamycin is my specialty, so I certainly wouldn't want to say that I'm an expert in any of those places.
I guess I'm thinking like metformin and NAD, like the things where I know
in the longevity field, right? I think there are other candidates that come out of the longevity field. So here's what I would say. Things we know with very high confidence work well and work every time to target the biology of aging, and these come from laboratory studies, are caloric restriction and rapamycin. It's a pretty short list. There are other things where so that's kind of the top tier.
Okay.
Second tier down would be things where there's been a report, maybe it hasn't been replicated yet, or maybe there are like a couple of papers saying it increased lifespan and then a couple of papers saying it didn't, and nobody really knows why. So that's kind of the next level down. I put NAD, metformin in that group. There's some intriguing things like urolithin A, which is a natural product actually that can induce something called mitophagy, so it clears damaged mitochondria. That looks really interesting to me. I might even for now put that above metformin and NAD.
Interesting.
So I've got my own sort of ranking in my head. But really, there's nothing that's on the gold standard list, in my view, other than caloric restriction and rapamycin. And then there's other stuff that's kind of the next level down. The thing about metformin, we know a lot about clinical use of metformin. So there's human data you can point to suggestive that, at least for certain diseases of aging, metformin can have benefits. Maybe it would be beneficial for things like long COVID. I certainly could see the rationale for doing those sorts of trials. It's a pretty safe drug, maybe not as safe as most people think it is, but it's pretty safe. And NAD precursors, or NAD, that's probably very safe. So there's not a lot of downside to testing it. And again, you can come up with plausible biological mechanisms where something like NAD could be beneficial for certain types of conditions. Personally, I don't think NAD is a general anti-aging treatment, but I think there are certain conditions or certain individuals who have deficits in metabolism where their NAD is depleted, and I think for those people, NAD can be quite beneficial. So I don't have enough confidence in anything to really put it at that same threshold as rapamycin yet. But I think there are a bunch of interesting things that are kind of the next level down that should be looked at for sure in some of these conditions.
I'm sure you've heard or maybe seen some of the data on metformin with COVID. How it seems to be reducing long COVID and reducing bad outcomes. Do you have any thoughts about why that might be? And is it an antiviral mechanism?
I don't really know, is the answer. And I think one of the challenges with metformin is it has many targets, right? So even for its anti-diabetic effect, most people would say that's mediated through a protein called AMP kinase, but metformin is not a direct activator of AMP kinase. So how metformin is activating even AMP kinase isn't completely understood. It's a mitochondrial inhibitor. So some people will call it a mitochondrial toxin. Certainly at high doses, it is a mitochondrial toxin. But I think one of the challenges, we don't know everything that metformin does because it hits so many targets in the cell. And even the mitochondrial mechanism, or AMP kinase, which is sort of a key regulator of central metabolism, could have antiviral effects through, complicated downstream mechanisms. So I just think we don't really know. At metformin, there's certainly evidence that in some contexts, metformin can be anti-inflammatory. So that could have be part of it, right?
Sure.
It's not the same kind of anti-inflammatory as rapamycin, but I can have anti-inflammatory effects. That would be my guess. Like if I had to point to one thing and say, here's what I would speculate it is,
Mm.
it's probably through this sort of non-specific anti-inflammatory mechanism. Now, interestingly, there are people who are concerned about metformin in part because of these non-specific anti-inflammatory mechanisms and its impact on the beneficial effects of certain types of exercise. So there's a body of literature now that's accumulating that metformin may blunt some of the beneficial effects of exercise,
Mm.
either in part due to its mitochondrial effects or in part due to its non-specific anti-inflammatory effects. So metformin is just a hard drug to really pin down because of how non-specific all of its effects are.
Do you think just knowing what you do know about it, taking a very short course, let's just say 10 to 14 days during the acute phase of COVID, do you see any real harm in that? For, obviously, people have to check with their doctors, but just
Yeah.
as a, in a general sense.
Yeah. So again, my speculation, I'm not a doctor, I'm not an
Yeah.
MD. I am a doctor,
Yeah.
just not an MD.
Yeah.
My speculation is no, there's probably not very much risk. So the only concerns I really have with metformin are around, I mean, some people get gastrointestinal upset, things like that, but my concerns are around this exercise blunting effect.
Uh-huh.
Again, I'm not saying that's completely solid, but there is data to suggest that's probably that can have an effect, blunting exercise. Or in men, this is not widely appreciated. Many men experience a decline in testosterone when they're on metformin.
Uh-huh.
But I don't think a 14-day course would be likely to have any impact, significant impact on either of those. So I see
Yeah.
very little concern there. You know, personally, my view is if for people using metformin off label, I don't think that's a great idea for people who don't have some sort of, you know, metabolic complication.
So what accelerates aging? That's one thing I've been wanting to talk to you about for a long time is just environmentally, things that we're eating. How do we understand that and what we can do about it?
Yeah, so I mean, I think an important concept for maybe people to appreciate is that, you know, these lifestyle factors that we know affect health
Mm-hmm.
are almost certainly affecting health because they modulate the biology of aging. So I think the reason why, you know, a healthy diet, regular exercise, sleep quality all have an impact on multiple age-related diseases is precisely because they are impacting the biology of aging, right? They're modulating the rate at which our bodies are aging. And so when you look at it from that perspective, the things that accelerate biological aging from a lifestyle perspective are presumably things like a poor quality diet, certainly metabolic disease, I think, seems to accelerate biological aging, sedentary lifestyle, high stress. There's good evidence that that can impact the rate of aging. There's also a genetic component. I mean, I think the data suggests that the environmental component, which is where lifestyle would sit, is probably about 75 to 80% of the longevity piece, right, for life
Uh-huh.
expectancy. But 20%, 10% to 20% is genetic. So you can't do anything about the genetic part, but you can do stuff about the environmental part. And so I think that's what people should appreciate is that, you know, you really have the opportunity to have a relatively large effect on your health span and potentially lifespan by modifying your environment. And, you know, you talked earlier about the presence of pollution or toxins in the environment, right? That also can have, we think, an impact on biological aging.
Sure.
Certainly, there's good evidence. So there's a scientist named Tuck Finch at USC who's been studying the effects of pollution on aging for a long time. And there's good evidence that high pollution levels can accelerate the rate of biological aging. So again, these are all things that we can modify to some extent and have an impact on our likelihood of achieving longer, healthier lives.
How do you approach your own diet?
Yeah, so it's funny because, you know, I've been in this field for probably 25 years, and it's only been the last 4 or 5 that I've actually taken control of my own health. So that's one thing I would say. Like, I think, you know, the first step is to really take control of your own health, start to learn about how you can both figure out where you're at. So I think there's a
Mm-hmm.
component here of identifying, where you're at on your own health journey,
Mm-hmm.
and using things like preventative screening or biomarkers to figure out where you're at, make sure
Yep.
that if you've got a problem, you get it taken care of. And then you can start to actually move to get yourself onto the best trajectory that you can get on. So, this has been an evolution for me even over the last few years. But, I think I sort of align on, I don't like the idea of one size fits all solutions. So I certainly don't buy into the idea that, intermittent fasting is right for everybody or ketogenic diet is right for everybody. I
Yeah.
think so. It's hard to say like what is the best diet for healthy aging. I think what we can certainly say what are the components of an unhealthy diet and try to take those things out. And so
Like what?
from a very simplistic level, I think highly processed foods clearly are a big problem. They've contributed to the obesity epidemic in
Yeah.
the United States and other countries. To the extent you can avoid them, take them out. Sugars or foods with lots of added sugars, same thing, right? They have very little nutritional value, clearly contribute to metabolic disease. To the extent you can, take them out. You
Yeah.
know, and I think if people do that, and again, it's a very simple rule of thumb, but shop around the edges of the grocery store. Try not to go down the aisles, right?
Yeah.
I mean, I think there's a lot of truth to that. So,
Yeah.
so that I think once you do that, then you can try to figure out among the options that are out there for a healthy diet, which seems to work best for you. And again,
Yeah.
I don't think there's a one size fits all. So that's sort of where I land. I think, what works pretty well for me is I tend to eat a diet that's relatively high in protein.
Mm-hmm.
And like I said, I cut out and I continue to get better, but I've cut out most processed foods,
Mm-hmm.
and most foods with added sugar, lots
Mm-hmm.
of fruits and vegetables.
Yeah.
Obviously, I like red meat, so I still eat red meat from
Mm-hmm.
time to time, but I don't have it for every meal.
Mm-hmm.
And that seems to work pretty well for me. So that's it on the diet side. And then on the exercise side, again, I think regular exercise is really, really important, obviously.
Yeah.
I think where most people, like, I'm not one of those people who says that, resistance training is more important than cardio training or that you need
Sure.
to do HIIT or any of that stuff. I think if that works for you, great. I do
Yeah.
say where I would say most people um, don't do as much as they should is in the realm of resistance training. So whether that's weights or body weight training, I
Mm.
think as we get older, maintaining muscle mass is really important. And most people don't do as much there as they should. So again, that's not going to be true for everybody, but I think as a generalization, I think most people should pay more attention to what can I do to maintain muscle mass as I get older, prevent frailty, prevent falls, things like that. So that's pretty much what I focus on for my own health. And then I think I mentioned these sort of diagnostics and biomarkers. Again, I think regular, blood work. Unfortunately, you have to go beyond what you're going to get with your primary care doc. So the
Yeah.
things that I think most people are missing are key vitamin deficiencies. So vitamin D, B12,
Yeah.
omega-3, things like that you may not get with your regular primary care. Get
Mm-hmm.
those measured, every 6 months optimally, I think is about right, at least
Mm-hmm.
until you get in the optimal range.
Okay.
I really like DEXA as a body composition tool. So
Oh,
find out your bone density. So a lot of people don't know. They're never going to know if they have a low bone density till they get a fracture, right?
yeah.
Find out your bone density, find out your visceral adipose. So that's the fat that's under the muscles in your abdomen. That's
Okay.
the fat that drives a lot of inflammation. So if you've ever heard the term skinny fat, those are people
Yeah.
who might actually not have a high percent body fat, but they've got a lot of visceral adipose. And so that can drive
Yeah.
metabolic dysfunction and inflammation. So I really like DEXA as a tool. Again, maybe every year, so you don't need to do it all the time, but it can kind of tell you where you're at and maybe what are some of the personal things you need to do to get yourself into a better place in terms of body composition.
Can you do anything about bone density issues?
Yeah, I mean, there are medications that can be taken for osteopenia or osteoporosis, but also resistance training is very potent at preserving bone density as we get older. So that goes back to what I was saying before, that I think not only is resistance training good for maintaining lean mass, it's also good for maintaining bone density and bone function.
Do you try to eat organic? I've become way more aware even just of eating restaurant food and how poor like the oils are that I'm eating.
Yeah, no, we definitely try to eat organic. I mean, again, I think if you can, you absolutely should, right?
Sure.
Unfortunately, there's all sorts of disparities in healthcare and
Understand.
socioeconomic status and
Yeah,
all of that, and access to good food. So I wouldn't want to say that that you should just give up if you can't eat organic. But if you're able, yeah, absolutely, we try to eat organic. I think what you said about eating out is also really important. You often can't control the quality of the ingredients that go into the food that you're eating if you eat
that's
out
right.
at restaurants a lot. Whereas if you're eating in your own house, you can. And so you should just be aware of that. And I think, again, as much as you can, eat healthy foods that you can actually control. And usually that means eating foods that you make in your own house.
Yeah, it's interesting that you talked about pollution being a factor because up until the pandemic, I spent, I would say, a third of the year in LA working and the rest of the time here in New York. And everybody in LA definitely, I know there's pollution there, but they do look less stressed. They do look less harried, and they do look younger. Now, I know there's a lot of Hollywood people are doing a lot of things to look younger, but it is sort of stark. And I do wonder about the pollution here because we're just surrounded by it. And again, like COVID has made me much more cognizant of air quality.
But certainly
Yeah,
pollution plays a role. And, this is a place where I think the Dog Aging Project has an opportunity to really identify some of the specific correlations here. Because we get zip code data on all of the dogs in the longitudinal study, we know a lot about air quality, even down to the zip code, because that's monitored. And we can start to correlate in dogs, what are the relationships between age-related health outcomes and different types of pollution that are present in the environment. So no doubt that it's important. That's a harder thing for a lot of people to be able to control. So there are only so many steps you can take. I know you guys got a lot of wildfire smoke this past year. We
we did.
get a bunch in Western Washington almost every summer. So that's something you can't really control. So you can only do what you can do. But I think being aware of how these things affect your health is the first step.
Yeah. I mean, I think at some point, some of us, we may move or we may make a different decision between
Sure.
this house and this house. This one's closer to the highway, so I'm going to have more risk of pollution. This one's further. There is data on that kind of stuff. And I completely, the moving is like the worst thing in the world. But I feel like, if you know this stuff and you're at a point where you're going to make a change, it's probably good to know if you have a couple
Yeah.
of choices. These
Yeah.
kind of things could help. So I want to talk to you before we go a little bit more about where you are now with the Dog Aging Project. We're all dog lovers at Bay Area Lyme Foundation, and like I would say, sort of excessively crazy dog lovers. Actually, she's sleepwalking right now, coming over to say hi to you. And how can we help you sustain this project?
Is wow. Hey, Lucy.
Say hi, Lulu. And
Okay,
she's
yeah, you're
looking at
right.
my husband like, is there food going to be involved in my life soon?
How
Anyway.
cute.
Oh, I know. She's
He
my
looks
baby.
great.
Thanks. Oh, okay. So yeah. So what can we do to support you? I don't know for sure. Are you definitely losing your grant from NIH? And
Right.
what do you need? What can we do to help?
Yeah. So just to give a little background, as I mentioned, the Dog Aging Project was first funded in 2018 with this large
Mhm.
grant. NIH cycles are typically 5 years, and that grant is not being renewed. And so then, the reality is that's about 90% of the project's funding. Without that grant ends in end of May. The project will have to shut down. There's almost no end to bureaucratic incompetence. That's
Yeah.
what I would pin it to. So
Yeah.
there, it's complicated. The staff at NIA recognize that this is a mistake, that it's a problem. They don't have a mechanism to solve it in a short period of time. It will be about
Yeah.
18 months to resubmit the grant. So the reality is the project can't survive that long. So the leadership of the project, we're working both on trying to get additional NIH funding. That's not going to happen quickly, but I think that will definitely happen at some point. And also, we have started a nonprofit, a 501c3 called the Dog Aging Institute. The website
Hmm.
is dogaginginstitute.org,
Mm.
where we are trying to raise philanthropic funds, at a minimum to tide the project over. But we've been thinking for a while, this was something that we needed to do to sort of ensure long-term stability of the project, but also to support research on companion animal health, dog health more broadly speaking. So that's the goal for the Institute. The short term is to maintain the dog aging project. The longer term is really to build an opportunity for more scientific research in this area. And so we're looking to raise, we feel like it probably takes about $2 million to keep the project to the point where we are fairly confident we can get more NIH funding. And I think people need to understand, one of the challenges is this is a pretty large project. It's got investigators at multiple universities around the United States. It's got staff who need a job. And so these individuals, rightly so, are recognizing that their jobs are going to end at the end of May. And so they're starting to look for other jobs. And, with a project like this, when you lose all of your staff, these are really great people who are essential for the functioning of the project. Once they leave, right, it becomes very, very difficult to rebuild that. Not impossible, but that sets us back, a couple of years, honestly, probably. So we really need those resources to keep the core staff in place to be able to maintain the project. Now, we're not going to be able to continue to do things at the level that we were operating at previously, but that'll at least allow the project to be alive for 18 months, 24 months at the outside to get this additional funding. Optimally, the budget for the project is, at the level that we were at, is probably around $4 million a year. And, so I think our sort of stretch goal for the Institute would be to raise, maybe 50 million, enough where we could actually maintain much of the function of the project off of an endowment. So that's where we would like to get to. But I think for the short term, we really need to be successful, at least raising a couple $1 million to keep the project going.
There's no money in old drugs and old repurposed drugs. There's just not a lot of, and I don't know if this plays into the dog aging project and your funding, but is that a factor just in trying to get people to run these clinical trials? The cheap generic drugs just don't have the kind of sexiness that a new patent does that makes billions and billions of dollars.
I think it's certainly a factor. I mean, in principle, that should not be a factor for NIH funding, right? The goal of NIH funding is not to commercialize in general. But I think certainly that's a factor for us. It has been. Certainly we've had people who've said, this is really exciting. Is there a way to commercialize it? And there may be, but it's not the same as a drug where there's patent life on it. And I think, when it comes to rapamycin specifically, I think, that's absolutely been a factor in why there haven't been more of, as we talked about earlier, more clinical trials, even though the data is all there suggesting that there's a good reason to do the clinical trials. Companies aren't willing to invest in those clinical trials if they aren't going to have, patent life where they can then market the drug, with some exclusivity.
Yeah. Okay. That makes sense. Well, I can't thank you enough for everything. I have so many more questions for you, and I hope that you'll come back and we can keep talking. And as you learn more about what's happening with the dog aging project and you get results, we're on the edge of our seat, truly. Thank you so much for everything that you're doing to help the world, to help animals, to help their owners. Really, really appreciate it.
That's why I do it. Yeah,
I love
absolutely.
it. I love it. Thank you.
Thank you. It's been a pleasure.
Thank you for joining us for this episode of Ticktective, a program of the Bay Area Lyme Foundation. For more information or to get involved, please visit us at bayarealyme.org.